welcome to the 10th of our series of web-based seminars on best practices in TB control. Today's seminar will focus on HIV screening in TB programs. My name is Bill Bauer, and I'm the Director of Education and Training at the Charles P. Felton National Tuberculosis Center. We're a component of the Northeastern Regional Training and Medical Consultation Consortium at the New Jersey Medical School. And today's program is sponsored by the consortium. The simultaneous occurrence of TB and HIV has long been observed. It's described as a co-epidemic or a syndemic. And the reason is each infection makes the other one worse. These images from some well-known domestic and international programs that have alerted health workers and the public to this situation. Here's a definition of syndemic, which comes from the American Society for Microbiology, and that's described as the convergence, that's the coming together of two or more diseases that act synergistically to magnify the burden of disease. Synergistically means that the two added together is more than what their sum would normally be. In this case, the intersection and syndemic interaction between HIV and tuberculosis epidemics has had deadly consequences around the world, and until we get adequate control of the TB-HIV syndemic, we're not really going to be able to reach long-term goals of eliminating TB as a problem. It's interesting to note that probably about 20% of people in the United States with HIV are unaware of their infection status. So that kind of shows where the problem is and why we need to try to do something about it. Now, our faculty today are myself. Second speaker will be Philip Peters. He's from the Centers for Disease Control and Prevention in Atlanta. He's a medical officer in the HIV clinical epidemiology team. The next speakers will be Dr. Adrian Gardner, an assistant professor at the Warren Alpert Medical School at Brown University in Providence, Rhode Island. Mark Hodge, nurse administrator, Montgomery County Health Department in Maryland. And Susan Nutini, clinical nurse at the Miriam Rise Hospital Clinic in Providence, Rhode Island. To get us all thinking about how our own programs are doing in this area, I'd like you to think about this question. Approximately how many contacts to TB cases do you manage to screen for TB? Over 30% say a fairly small number like 0 or 25%, but another 30% are saying they do 3/4 to 100%. That's really interesting, that a distribution at both ends are the highest numbers, and in the middle it's about 15% each for those who are doing between like 1/4 to 1/2 or 1/2 to 3/4 of their patients. Now that we've thought about this, let's see how we compare to the guidelines. Our first speaker will be Dr. Philip Peters. He's a medical officer with the Division of HIV/AIDS Prevention at the CDC in Atlanta, and he's responsible for conducting epidemiological and biomedical research activities to evaluate acute HIV infection and important HIV-related co-infections, of which TB is a prominent one. And his professional interests include improving HIV diagnosis in the clinical setting. Philip?
Thanks so much, Bill. Thanks for that great introduction. And thank you for the opportunity to participate in this webinar and discuss HIV screening recommendations for patients 13 to 64 years of age. I have no conflicts of interest, and included is our standard CDC disclaimer here. And I'd also like to start with a question. What has been responsible for the greater than 95% decline in perinatally acquired AIDS in the United States? This is great. I thought this would be a softball question, and it was. Everyone is getting the right answer, number 4. It's been both the widespread screening of pregnant women for HIV infection and then antiretroviral treatment that has resulted in this dramatic decline in perinatal HIV transmission. And this is despite the actual increase in the total number of HIV-infected pregnant women who have delivered year after year. And the reason we present this question is that it's really these same principles that we're now trying to apply to adults and adolescents to prevent sexual and injection-related HIV transmission in the U.S. So let's now review the actual recommendations. They were published in 2006 after consultations with clinicians, patients, public health officials, and are freely available online. They've been endorsed by a number of medical societies, including ACP and AMA. And in the years since their release, there have been a lot of changes to state health laws that have made their implementation more feasible. Here are the major recommendations. All patients aged 13 to 64 years who access healthcare settings should receive at least one HIV test as part of their routine care, regardless of their reported risk information. The test should be offered as an opt-out test, meaning patients should be told the test is being done unless they want to decline testing. The testing should be offered in settings where the prevalence of undiagnosed HIV infection is greater than 0.1%. Now, usually this prevalence is unknown before you actually start testing more widely, and that's okay. Written consent and prevention counseling is not required prior to performing the HIV test. And if patients do report high-risk behavior, such as men who have sex with men, injection drug use, or having been diagnosed with a sexually transmitted infection, then testing should be repeated at least annually. However, people with no known risk factors who have previously tested negative do not need to be screened again when they access health care, unless it's clinically indicated or there's a new risk factor. I'd like to review 4 topics during this talk. First, we'll analyze the rationale for these HIV screening recommendations. Second, we'll assess the clinical benefits of routine HIV screening. Third, we'll discuss approaches to simplify the provision of HIV screening. And finally, we'll discuss an update on selecting an HIV test. The primary rationale that was alluded to by Bill for HIV screening is the relatively high prevalence of HIV in the U.S. and the significant number of people who are unaware of their HIV diagnosis. In 2008, it was estimated that over 1.1 million people were living with HIV in the U.S., and that corresponds to about a 0.4% prevalence in the population. Most concerning has been the finding that about 20% of these people are unaware of their HIV diagnosis and therefore unable to benefit from life-saving antiretroviral therapy or HIV prevention. Now, although all regions of the U.S. are impacted by both HIV and tuberculosis, some regions are disproportionately impacted. These 2 figures graphically show the rates of AIDS diagnoses by metropolitan statistical area on the left, where the larger blue circles correspond to higher AIDS rates, and the rate of TB cases by state on the right, with the states with higher rates shaded blue. As you can see in both situations, the Northeast and the Southeast and also the West are disproportionately impacted by these infections. So the next issue is why routine screening instead of a risk-based screening approach where you only test people who state they are at high risk for HIV infection. The main reason is that patients often don't disclose their risk and may not even be aware of their risk. In a survey in New York City, 39% of men who had sex with a man within the past year did not disclose this to their healthcare provider. In another study of HIV testing in emergency departments, 51% of people who were diagnosed with HIV infection reported that they had no risk factors for HIV at the time of testing. In general, risk-based screening has become less effective, and a key location where we miss people with risk-based screening is during healthcare visits. In a study of people newly diagnosed with HIV infection, the average person had a median of 7 healthcare visits over a 5-year period before their HIV infection was diagnosed. An additional problem of risk-based screening is that it fails to identify certain groups of people who are HIV infected, including young people, women and heterosexual men, also people who are racial or ethnic minorities, and also people who live outside of urban areas. The downside of a risk-based approach is that we often diagnose people at a late stage of their infection when they start to develop late-stage clinical symptoms. Among persons with newly diagnosed HIV in 2009, 32% developed AIDS within 1 year of their initial HIV diagnosis. These persons likely were infected an average of 10 years before they were diagnosed. Late diagnoses of HIV infection is a problem because these people are at high risk to acutely develop opportunistic infections and other serious AIDS-related complications that are associated with morbidity, death, and healthcare expenditures. This chart shows the prognosis over 5 years of HIV-infected patients who are just starting antiretroviral therapy. As the graph shows, the probability of death increases as the CD4 count decreases. This emphasizes the need to test and diagnose patients earlier, for example with a CD4 count greater than 350, so that antiretroviral therapy can be started earlier and patients can enjoy a better survival. The rationale for testing and clinical benefits of early diagnosis that we've discussed are applicable in all healthcare situations, but as you know and will be discussed further in subsequent talks, there are particular interactions between tuberculosis and HIV that make HIV screening even more relevant in this setting. First, a high proportion of people with tuberculosis disease in the U.S. are HIV infected. Second, compared with HIV-negative patients, HIV-infected patients with M. tuberculosis are markedly more likely to develop active tuberculosis disease. So among your patients with latent TB infection, there also is a really pressing clinical reason to know their HIV status. Now, in addition to the clinical and survival benefit of diagnosing HIV earlier, there is also a public health benefit. HIV treatment with antiretrovirals leads to a suppression of the HIV viral load, which makes it very difficult to transmit HIV. This slide is from the HIV Prevention Trials Network Study 052, where they demonstrated that antiretroviral therapy reduces heterosexual HIV transmission by 96%. But again, to realize this prevention benefit, we must first diagnose HIV infections early and then be able to link and retain people in care. To summarize, HIV screening leads to new early HIV diagnoses, who then can be linked to clinical care. This chain of events results in two outcomes. First, it improves the quality of life and survival of patients who have HIV infection, but it also decreases the risk of HIV transmission to others. At its core goals, HIV screening, much like TB testing and treatment, is an effective care tool that can save lives and prevent disease. The key to implementing HIV screening is to try to integrate it into the daily operations of a practice. Most states now allow staff to perform opt-out HIV testing, where patients are informed that we are performing an HIV test as part of their standard medical evaluation, and they can decline if they do not want testing. We also no longer recommend extensive pre-test counseling. As an alternative, providing patients information materials can be useful. And at the end of the talk, there's a link to how some of these materials can be obtained. Finally, being prepared for common questions and to address patients' misperceptions is also key. A common example is that many patients think they've had an HIV test if their blood was drawn previously by a doctor, when in fact we know this is likely not the case unless someone explicitly told them an HIV test was being performed. Of course, HIV testing should be consistent with state laws, and until the last few years there were some issues that made these routine HIV screening recommendations difficult in some states, including Massachusetts, New York, Pennsylvania, and Rhode Island. In particular, requirements about a dedicated and detailed HIV-informed consent. But through a lot of hard work by clinicians, health departments, and community organizations, there have been revisions to these laws, and in general there has been a phasing out of the requirement for a separate written informed consent. This website provides up-to-date information on state HIV testing laws, although I believe the most recent updates from Massachusetts and Rhode Island might not have been added quite yet, but they should be soon. Now, while we encourage the provision of HIV testing to be integrated and streamlined into clinical practice, the provision of a positive HIV test is the aspect of HIV testing that must be done deliberately and thoughtfully. The patients who test positive on their initial test, whether it's a rapid HIV test or an ELISA test, should have an HIV confirmatory test performed to confirm HIV infection. These test results should be provided to them directly and personally, and a positive test result should also be disclosed confidentially. When discussing a positive test result, the healthcare provider should make sure the patient clearly understands the test result. And connecting to services is an important step for patients with a positive HIV test result. How a patient will be connected to HIV clinical care is really a critical issue that must be worked out when you're providing HIV testing. So now I'd like to finish the talk with a brief review of some of the HIV tests that you may use in your practice. When you perform an HIV test, you have two major options. One is to obtain a blood sample and send it to the lab for traditional lab-based HIV testing. The other is to perform a rapid point-of-care HIV test. These pictures are of 6 rapid HIV tests that are available in the U.S. They test for antibodies against HIV with a finger stick, and one is able to test oral fluid. Now, rapid tests have been an important advance in HIV testing technology. They have many advantages, including ensuring the patient gets their test results, which is particularly important when you're bringing testing into the community. And there's also the option to do an oral swab or a finger stick instead of a blood draw. But they do also have limitations. the results of a rapid test are manually read and charted, so depending on how your medical record system is set up, it may not be easy for a person in the viral hepatitis clinic, for example, or the emergency room to see the test results. Training and oversight is necessary for any staff who are performing rapid testing, and rapid testing can overburden nursing and other staff if the patient flow issues are not carefully considered. Finally, rapid testing is actually more expensive than sending a blood sample to the lab. Another problem with rapid testing and HIV testing in general is that we have not been able to detect the earliest phase of HIV infection called acute HIV infection with these tests. And that's because there is an antibody window period with HIV infection. In this figure, the x-axis represents days since HIV infection. There are also 3 lines labeled HIV RNA, HIV P24 antigen, and HIV antibody. These 3 markers of HIV infection can be measured in the blood, and the height of these lines represents their relative concentration. As you can see, HIV RNA becomes detectable first after HIV infection, and that's followed by P24 antigen, and lastly by HIV antibody, which is initially an IgM antibody and then later is an IgG antibody. The acute HIV infection window is defined from the earliest detection of HIV to the point where most HIV antibody tests start becoming positive. And the relevance of this window period is that if your patient is being tested for HIV at this time, the HIV antibody test would be negative despite HIV infection. A significant recent advance in HIV testing has been the development of a combination HIV antigen antibody test that can directly detect P24 antigen as well as HIV antibody. This assay provides us with a way to detect this early acute phase of HIV infection with our initial screening test. Currently, it is a lab-based test, and there are 2 lab-based tests that are on the market, but they can be performed very rapidly, and they are increasingly being used in hospitals. And there's hope that in the future, there will also be a rapid test version of this as well. Thank you again. We moved through a lot of topics related to HIV screening, and I appreciate the opportunity to discuss these recommendations and related issues. This slide has reference to materials that have been developed by CDC that relate to HIV testing and can be either downloaded at our website or ordered using the information available here.
Thank you, Phil. It was a very useful review of the current guidelines, and you touched on a lot of the practical considerations in a thorough way. I think that all of us listening can appreciate the importance of following these guidelines because you pointed out the benefits if we make the screening a routine part of care, especially for evaluating contacts. But many of us can imagine a ton of barriers that might be in the way. Do we have the resources? Do we have the commitment? How do our programs stand ready to go ahead with this? To begin looking more at this, I'm going to turn the program over to Adrian Gardner. Dr. Adrian Gardner is a graduate of Brown University and Brown Medical School, as well as Harvard School of Public Health. He completed his residency training in internal medicine at Beth Israel Deaconess Medical Center in Boston, and he's worked in the Rhode Island TB control program, as well as in Eldoret, Kenya. And in fact, he is calling in today to this webinar from Kenya. Adrian?
So let me just start by making any disclosures. I really have no relevant conflicts of interest, and the information I'm going to present today was actually a survey conducted and analyzed by an undergraduate student at Brown, now a first-year medical student by the name of Caitlin Narikis. Her results were presented at the North American Region meeting of the Union, and there's a manuscript in progress. The survey was actually conducted via an online survey tool, and we really designed it to assess the extent of opt-out HIV testing as well as TB providers' knowledge and perceptions of current guidelines and really their current practice. One of the challenges we encountered was that there's actually no comprehensive list of TB providers in the United States. So we ended up sending the survey to a number of listservs and conference attendees to the 2011 National TB Conference. One can imagine that many of these people who attend these conferences or on these listservs aren't necessarily TB providers, so it wasn't surprising to us that we had a fairly low response rate. Obviously a limitation of the study, we don't know exactly who responded. There were only about 6% of this large audience who responded, so it may be a slightly biased group, and it may limit the generalizability of our conclusions. Still, I think there were some interesting lessons that we could take from this. The majority of respondents were nurses. There were about 20% physicians, and another 12.4% identified themselves as public health practitioners. Despite this fairly low response rate, about 39 states were actually represented. And as you can see, about 2/3 of the group spent more than 5 years in TB care, working in TB clinics, and so fairly experienced TB providers. We asked people how important is HIV testing, and we asked about specific patient types. And what you can see here, the respondents thought that HIV testing was more important in those with active TB or those suspect active TB compared with those who were contacts or those with latent TB infection. So you can see those two middle graphs have a lower number of people who thought this was very important or important. We also asked people in your clinic, are patients with the following diagnoses routinely tested for HIV? And you can see that the perception is really mirrored by the current practice, such that 92% of people reported that patients with TB disease were always or almost always HIV tested. This compares to, in the same year, the CDC reported about 81% of active cases of TB were HIV tested. You can see that for latent TB-infected patients, the number was significantly lower, so only 42% of respondents reported that they routinely test patients with LTBI. And in terms of all patients seen in the TB clinic, the number drops further to about 37%. Clearly, we can do better if our guidelines are telling us to test everybody. We asked people specifically about some of the barriers to incorporating routine opt-out HIV testing for all patients. And you can see here the main ones were burden of obtaining written informed consent. Patient refusal of test was interesting. That was the only one that actually a majority of respondents identified as a barrier. So more people identified that as a barrier than didn't. And then cost was also a common one. But you can see there were a number identified: administrative burden, requiring too much provider time. Interestingly, patient refusal of test was noted both by people who are actually already implementing HIV testing and those who are not HIV testing. Another interesting finding was that 59 respondents, about 40%, reported that their state required written consent for HIV testing. However, only 12 of these actually were from states that required written consent at the time of the survey distribution. Now, this may be a little unfair because, as Dr. Peters noted, some of these states have recently changed their rules, but it does point to a lack of knowledge about the current law, even within the states that people are working in. Another 7 respondents reported that they didn't know whether the written consent was required or not. Finally, we asked people just a straight-up question: how do you think routine opt-out testing would be feasible and acceptable in your setting? And we can see that despite the barriers that were identified, a majority of respondents are either already doing this or believe it to be feasible and acceptable in their clinical setting. Given the limitations of the study's limited generalizability, however, I think we can safely conclude that significant work still needs to be done to promote the integration of opt-out HIV testing into routine care for all patients affected by TB. Noteworthy that fewer than half of respondents' care settings have an opt-out HIV testing policy for latent TB patients. This indicates a true missed opportunity, I think. And although providers tend to report acceptance of the need for universal testing, they set a long list of barriers, some of which are no longer valid, particularly the consent procedures by state. I think this represents a teachable moment as well as a potential funding opportunity for partnerships for TB care.
Thanks a lot, Adrian, for sharing this national perspective. With this survey, it really showed, I guess, that there are a lot of perceived barriers, but they may not be as bad as we fear. I think probably the barriers can be overcome, and that's what we'll start seeing now with the next speakers, be it at the level of a state program, a county program, or an individual program. Now I'd like to turn the webinar over to Mark Hodge. Mark studied nursing at the University of Maryland, Baltimore, and healthcare administration at the University of Maryland University College in Adelphi, Maryland. He's worked in pediatrics, school health, immunization, refugee health, and tuberculosis control. Presently, he's the nurse administrator in charge of the TB prevention and control program of the county that reports the most TB cases in the state of Maryland. Mark?
Okay, this is Montgomery County. We are a fairly regular-shaped county within a very strangely shaped state. D.C. is right here in this little square underneath Montgomery County, so just to give you some perspective about where we're located. This is a 2000 census for a population of 873,000. The last census, we were over 980,000. We're expected to be over 1 million within the next couple of years, so we continue to grow. People are moving out of the cities and into the suburbs. Montgomery County TB, 2011, we had 73 active TB cases, a case rate of 7.6 per 100,000. That's double the U.S. case rate. It's also almost double the state rate for Maryland. We see 1/3 of all the active cases in the state of Maryland. Non-Hispanic blacks and African Americans represented about 33% of our active TB cases. And as I talk about HIV for that population as well. In recent years, here in Montgomery County, we've had 5 to 8% of the people with active TB who are co-infected with HIV. That number is going to spike this year. We've had actually 5 co-infected patients just in the last 3 or 4 months. We're going to have a huge spike for 2012 for that. Some information about those patients. 3 were newly diagnosed HIV patients. They claimed they did not know about their HIV status prior to diagnosis. All were foreign-born, and 2 had just gotten off the plane from their home country when they arrived here with HIV and TB. These are the most recent official statistics we have in 2008, more recent years, but the case rate of Montgomery County at least have remained pretty stable. 2008, Montgomery County had 3,008 cases of HIV and AIDS, case rate of 316 per 100,000. Also double the U.S. case rate here in Montgomery County. Non-Hispanic Blacks, African Americans represent 16% of the county's population, but 71% of the HIV cases diagnosed in 2008. Most of them are actually African nationals, and it's also a large number of our TB cases. We are actually located in the exact same building as the HIV clinics. The TB and HIV are just down the hall from each other. We're also located with the STD clinic, disease control, immunizations, and refugee health program. We're pretty much the communicable disease building of the whole county. If it's a communicable disease, you're going to find it here in this one spot. I'm not sure our neighbors are very happy about hearing that. It's very helpful that we're all co-located because we can really work together well. This is our building. The grass is mowed. That's a good sign. The first thing to go in budget cut is grass cutting, so we just got lucky on this day. But we are getting a new building in the next couple of years, a brand spanking new building. This is an old school building from the late 1950s. The HIV testing is provided as a service of the Montgomery County STD Clinic to all county residents. We have those who can come into the STD clinic here and get tested. We also have some satellite clinics where they can get tested for STDs and HIV. All clients with active TB are offered an HIV test by the TB nurses, so while they're here in the TB clinic, they are all offered HIV testing. And we do it when all the other labs are drawn. So we're drawing LFTs, we're drawing CBCs, we're drawing IGRAs, we do the quantiferon here. We tend to try to draw everything at the same time. HIV is really just included in the list of the tests that we provide, so we don't really single it out. It's very rare for anyone to actually refuse the HIV testing since we're already sticking them for other tests. Occasionally we have people who actually ask specifically to be tested for HIV. In 2007, 69% of our clients had a known HIV status. Last year in 2011, it jumped up to 84%, so we're doing a much better job of making sure that we have everyone tested. If you take out kids under 13 and adults over 64, some of our patients who have died in the hospital before we ever saw them, that number actually jumps up to 97%. So we're really, of those who need to be tested and those who have access to testing, we really get almost 100% HIV tested, which is a very good thing. Treatment for our active and latent TB cases for those with co-infection for HIV. Patients are co-managed. All treatment for active and latent TB is done in the TB clinic. All of their HIV care is provided in the HIV clinic. So we work together, the case manager in TB and the case manager in HIV. It's just one in each clinic are responsible for all the co-infected patients. They speak together quite frequently. They try to make the appointments on the same day, around the same time, so the patient can be seen in the same building. The co-management of patients is really closely and really well between the two nurses in those two different programs. Discussing some barriers, although it's entirely possible that they are no longer barriers for us. Language was a big barrier. We have 12 languages that are spoken in the building, so that helped tremendously. We also have access to the language line that we use quite frequently for use with our patients who don't speak English well or not at all. Some of the cultural beliefs around HIV and TB, that's been a big barrier to us, partly in getting testing for HIV. For example, in Ethiopia, we realized through some research and some discussions with some of our Ethiopian patients, many are afraid to get tested for TB and or HIV because they seem to be comorbidities in Ethiopia. At least culturally, if they have one, then it's just assumed they have the other. To find out someone's HIV positive might also mean that they're positive for TB, and so it's a little scary for them. A lot of education around those two diseases being very different and the way you get them very different can be really helpful in getting them to be tested. We provide cultural competency training. The state of Maryland has really put some money into providing cultural competency training for TB nurses, especially our refugee health program in the last couple of years. One of the other barriers, and hopefully this will be addressed fairly soon, is right now where there's documentation that's occurring in two different charts, the TB chart and the HIV chart. The county is moving forward with purchasing right electronic medical record. So that will be a huge improvement to the way we do things now to be able to share the record electronically instead of on paper in two different places. The other barrier is when trying to explain a lot of what we do and why the numbers aren't better is While we have the largest number of active cases in the state of Maryland at 73 last year, it's still a relatively small number. So when you're looking at statistics and other data, one or two people can really throw off percentages. It's not necessarily a barrier in providing testing, but certainly a barrier in being able to explain to the policymakers why we're not doing a better job. That's the big red arrow that leads into the TB program. Our security guard is often directing people to the big red arrow and then answering the question about where the big red arrow is. We can't make it any plainer than that, I don't think. Some of our successes, communication has improved greatly in the HIV clinic and TB clinic, and we work very closely together and share results and treatment responsibilities. We meet frequently. The physicians in the two different programs met recently to discuss treatment options and increased LFTs. Having the one case manager in each clinic who deal directly with the co-infected individuals, huge difference. And collaboration has been helpful not only for us, but throughout TB and HIV, but for the other clinics in the building as well. HIV clinic received a grant to increase the numbers of blacks and African Americans tested for HIV. Since we, in the TB clinic, do approximately 30 QFTs every Tuesday, that's our IGRA day, it will be a great opportunity to put a staff member here to do HIV testing of those who just walk in for TB tests, not necessarily with latent infection or active disease, but just those who are walking in for clearance. That is my contact information.
Thank you, Mark. I think it really, for me, was a lesson in how improved practices and screenings for HIV can be incorporated into a sophisticated program that was already doing a lot right. Kind of shows me that no matter how good we think we're doing, that improvement still is possible, and that it's actually working together is part of the solution. I think you're lucky you're co-located with so many programs. Last, I'd like to turn the program over to Susan Nutini. Susan is a graduate of Roger Williams Hospital School of Nursing, and she's worked in tuberculosis since 1985. She was the nurse manager of Rhode Island's TB clinic from 1993 to 2001, and since 2001, she served as a part-time staff nurse at the Miriam Hospital Rise TB clinic. Susan?
Thank you for your introduction. I'm just showing you where we're located. Rhode Island is the littlest state in the Union, nestled between Connecticut and Massachusetts, and this is just a picture of our hospital. Rhode Island is a state of about 1 million people, with the capital city being Providence, and about 180,000 people in Providence. We have a large immigrant population, about 29.2% are foreign-born. We have a single TB clinic based at the Miriam Hospital. There's no other in the state, as you can drive to the state of Rhode Island in about an hour. We have 25 to 50 cases of active TB annually, and we treat about 1,000 cases of LTBI annually. The estimate for 4,000 to 4,500 prevalent HIV cases, 1,400 patients in care at the Miriam Hospital HIV clinic. This is just a broad overview of HIV cases in Rhode Island. As you can see, the predominant risk factors is men having sex with men, and the greatest population of HIV positive is in the Providence area. I'm going to talk about a case that prompted us all to think about missed opportunities. We had a 33-year-old woman who was referred to the TB clinic for an evaluation of a 22 by 22 millimeter PPD done during her prenatal care. She had been part of a contact investigation about 14 years earlier and was found to be TST positive, had initiated but not completed INH therapy. At her TB clinic visit during pregnancy, she had no symptoms, and she had a normal chest X-ray. Treatment for LTBI was deferred until she was postpartum. Coincidentally, I actually took care of the source case with her father when I was a newbie in TB. Following her TB clinic appointment, she underwent HIV testing during her prenatal care and was found to be positive. She was referred to the HIV clinic for initiation of antiretroviral and treatment, but her HIV status was not communicated to the TB clinic. Following delivery, she defaulted from HIV care and did not keep her appointment here in TB clinic. I should mention that TB clinic and HIV clinic are right across the parking lot from each other, and we work well together. 3 years later, she developed GI symptoms associated with fever and was eventually diagnosed with abdominal TB, retroperitoneal lymph node biopsy, smear and culture positive. This really was a missed opportunity. It prompted the doctors to think about incorporating routine HIV testing for all new and LTBI patients, and we started a trial on our Tuesday evening clinic. Barriers to starting the HIV testing were reluctance of the staff to add one more task in a busy clinic setting, discomfort of the staff members discussing HIV and offering testing, written consent forms were time-consuming and only available in English and Spanish. Rhode Island law has now been changed to do opt-out testing, but at the beginning we didn't have that. And how are we going to get testing kits and who was going to pay for them? Second set of barriers were lack of space for the specimen, disruption of patient flow in the clinic. The clinic is often standing room only, and how are we going to incorporate this? And would patients be driven away with the mention of HIV testing? There was also the need for the staff to be trained and certified in the procedure. Pros for starting treatment. It was important that individuals be screened and referred for HIV treatment if positive, important in stratifying the patient's risk of developing active disease, and as I said, very easy access to HIV care. Our hospital immunology clinic is next door, and compliance with CDC guidelines. Despite staff reluctance, and I must say I was definitely included in the person who was reluctant, we decided to give it a try. The nurses were all trained and certified with a 1-hour training. After initially borrowing supplies left over from a research study, funding was built into the grant that supports TB care. With practice, we all became more proficient and comfortable initiating testing, and surprisingly, patients were not upset and were excited to be able to get immediate results. I seem to find that I had a much greater success rate than I'd had previously when we were just doing the lab test. Rhode Island changed the consent law, and the hospital implemented verbal consent, which was a great help. The main obstacle for the staff was that we couldn't spend 20 minutes in a room waiting for the test to run. It disrupted the flow in the clinic. And working with the doctors, we set up a secure site in our doctor's office where specimens could be labeled, test run with individual timers, and MD or staff would check the results when the timer went off. Despite all the perceived barriers, we now have a smoothly running system. Testing is initiated by the RN. Post-test counseling is done by the MDs or the nurse. And patients with positive rapid tests immediately are seen by the MD. And staff from immunology clinic is involved as soon as possible, which is often immediately. Results to date, we've tested over 1,000 patients, and we have 2 newly diagnosed with HIV. And I'll go into those in a moment. The first case was a young, foreign-born Eastern European woman who had a PPD done for employment, had a positive TST, normal chest X-ray. She was single, monogamous, with the same boyfriend for 3 years. HIV result was from a lab-based test, not rapid. And this was a problem. It only highlighted for us the need for rapid testing. We had trouble getting her back. She missed several appointments. She was shocked by her diagnosis. It wasn't expected by the patient or by the staff. Confirmatory testing performed and linked to HIV care. Her initial CD4 count was around 900. She successfully completed her LTBI treatment, and she's actively followed an HIV clinic, not yet on antiretrovirals. She was truly, absolutely stunned by her diagnosis and had some difficulty accepting it, but has gotten into care. My second case was a young woman recently immigrated from West Africa. She was skin tested to begin work as a volunteer nursing assistant. Positive PPD, normal chest X-ray, rapid HIV positive. She was immediately seen by the TB clinic MD, and the social worker from the HIV clinic came over. She initially refused to believe the results, absolutely couldn't believe this had happened to her. The HIV social worker continued engaging her HIV while we in clinic focused only on her TB care. We really tried to keep it separate. She completed confirmatory testing at a related hospital, and her CD4 count was about 300. As of June of 2012, she has started antiretroviral therapy, although she still continues to believe that this can't possibly be right, and she's still receiving treatment here for her latent TB infection. Lessons learned. Universal opt-out HIV testing in the Rhode Island TB clinic is feasible, practical, and now well accepted by the staff and the patients. We really have got it up and running smoothly. Contrary to pre-implementation staff predictions, patient refusal rates were low. Potential barriers can be overcome, and HIV testing in this setting may be an effective way of reaching populations that do not otherwise have access to testing. Many of our patients are not followed anywhere else, and we try and hook them into care, but it's a good way to begin. The references are up in front of you.
Susan, thanks very much for taking us through the process. I know that often a clinician thinks they might know about someone's risk factors and they might think they should follow a hunch whether to screen for a condition or not. But your example showed us that's not always the best approach. And you guys have actually been convinced by your experience that making HIV testing routine is feasible and in the best interest of the patient. I see that we have time for discussion of all the presentations.
I need to understand what opt-out means. Thank you.
Okay, Dr. Peters, would you take that one, please?
Sure. Opt-out testing is basically when testing is offered to a person and said that would like to perform this testing as part of your standard medical evaluation, and the patient has the option to decline testing. Opt-in testing is specifically asking a patient, would you like me to perform an HIV test or not? And then they can say yes or no. And although it seems like a very subtle difference between the two, when people have looked at the psychology behind accepting an HIV test, if it's presented to the patient that this is a standard thing that we do as part of medical care, there's a much higher acceptance rate of the testing versus if it's thrown into the patient's lap to decide if they want it or not. That starts to make the patient think, I don't really have any risk factors, or is my provider going to think of me differently if I tell them that I think I do need an HIV test? So it sort of takes the decision a little out of the patient's hands unless they want to decline testing for a particular reason. Just to emphasize that opt-out test is what we recommend. And obviously anybody who wants to decline testing, that should be respected, but it should be encouraged, just like if you're going to perform a cholesterol test on somebody or a CBC for some reason, it should be offered in the same way that those tests would be performed.
Well, then I've got one question I would like to throw out to all of the speakers here, and that would be if you had to give two recommendations to anybody who is listening today about what they should do to go about incorporating opt-out testing in their programs.
This is Mark. One, you really have to know your state laws, because each state is a little bit different, so it's important to know what the requirements are for testing. I'm not quite clear about whether each state allows for opt-out testing, but that's my first recommendation, is to make sure you understand what your state law is around HIV testing. And the second thing is, don't be afraid to do it. As Rhode Island mentioned, we found here in Montgomery County, Maryland, that maybe 10 or 20 or more years ago, it was something that was scary to people, but we very rarely get anybody who even blinks at the mention of an HIV test anymore. While there is still some of that stigma and fear related to HIV testing, as clinicians, we need to kind of jump right in there and not be afraid on our own to do it.
I'm with Mark. I think people accept HIV testing much better than they used to. There is no one in the world that doesn't know what HIV is. And I think for us, I found that offering the rapid test and not having people go home and worry for a week has made a really big difference.
Susan, one of the barriers you cited was you were worried about how would you pay for the test.
Yes, because the testing kits are expensive, and we were lucky that they were able to incorporate it into our budget, so now that we have access to them.
Okay, so you used some from another program.
When we did the pilot study on the Tuesday evening, and it went so well after we got it down that we were able to approach them for more funding.
Here is a written question that came into us. It's for Dr. Peters. How do you propose addressing challenges of HIV home test kits and those individuals who test positive outside of the healthcare setting?
As most of you have probably heard, the FDA approved last month a home-use rapid HIV test, which is the oral fluid test. A patient can buy this kit in a pharmacy or order online. It's not currently available, but I believe in October of this year it's going to become available. So they can purchase this kit and then perform an oral fluid rapid HIV test on their own at home. Healthcare providers in all types of clinical settings will probably see situations where people come to their clinic and say, I did this at home and I have a positive test, or I did it and I don't know what the result means, or something like that. In these type of situations, the rapid HIV test would still need to be confirmed to confirm that this is actually an HIV infection. So what would be recommended is to counsel the person on that this test result was preliminarily positive as they're explaining it to you, and that you'd like to draw a blood sample so that the result could be confirmed. and then the person might need supportive services, etc. So you would need to take the time to explain those issues to the person. On the flip side, you might also have situations where people come in and say, I heard about this home use test. What do you think about it? That's probably a good opportunity to actually just offer somebody an HIV test and do it in the clinical situation. In general, that's going to be the recommendation that ideally we would like people to get their HIV test. I would like to have the HIV test performed in a clinical situation where we know the test is going to be performed and the person is going to get their test result back, etc. So I think you'll see both sides. People will come in and say they have a positive test result, and then they need to be counseled as if they do have a positive test result and get the test result confirmed. But you'll also see the curiosity factor as well, and that's probably a good opportunity to discuss doing the testing in a healthcare setting.
Thanks, Philip. Are your clinics doing HIV testing on all clients who come in presenting for a TST?
Here in Rhode Island, no, we're not. We're doing it when they come with a positive TB test at their initial visit. We're offering all new patients that have a positive TB test or a positive quantiferon HIV testing.
Mark?
No. We are not currently doing it on those just who are walking into the clinic.
And like the Rhode Island case, are you doing it on people who have a positive TST or have a positive quantiferon? Or do you have other criteria?
No, we're not typically doing that on positives either.
So here comes another question for all the clinicians present. How is the HIV testing approach different for pediatric TB patients versus adult TB patients?
For us in Montgomery County, I don't think there really is a difference in our approach. Obviously, we're not consenting the child as much as talking with the parent, but as far as whether we decide to do it or not to do it is not any different, regardless of age.
This is Susan. I have to agree with Mark. We're about the same.
From a recommendation standpoint, somebody has a clinical indication for HIV testing, such as tuberculosis disease, that would be an indication to test. So it wouldn't make a difference what their age is. If we're just talking about people from a screening for HIV perspective, the recommendations for screening would be for 13 to 64 years of age. So, for example, if a child had been in exposure to tuberculosis and there wasn't a clinical indication or other indication to indicate that you would do an HIV test, that wouldn't be the recommendation.
I do have two more written questions that have come in. One person's concern is, how do you ensure that most clinicians are comfortable with asking patients to screen for HIV without looking at any of the risk factors to ensure that there are no missed opportunities?
Well, we were all trained. It's part of our routine questions, and we're pretty matter-of-fact about it.
How do you deal with patients over 65 years of age who test positive for HIV and who are not willing to accept the results because they don't perceive themselves to be at risk?
I would just say that this is a situation that doesn't just happen with people who are over 65 years of age. And, in a lot of settings, when you look at who is getting an HIV test, a significant number of people who are, maybe 10 or 15% who are testing positive are people who are testing again. They were tested somewhere else the first time and they didn't believe the results. This is a situation with older people. And the recommendation for this age group from 13 to 64 is really based on the prevalence of undiagnosed HIV infection is highest in those age groups, but there definitely are people over 65 who are being diagnosed with HIVs. So the screening recommendation is not to say absolutely don't test people who are greater than 65, but it was felt that the prevalence was not high enough in this age group to warrant a blanket recommendation.
Thank you very much to all of you on the faculty here. If you're interested in more information or resources on dealing with TB and HIV, these fact sheets are a start. And last, I would like to remind everyone that for medical consultation questions, you can call 1-800-4TB-DOCS with any questions regarding medical consultation in the Northeast region. And this concludes the conference. Thanks very much.